Good afternoon. If you're watching this, that means that my internet connection wasn't really good enough in the middle of the Mediterranean, so I thank you very much for your patience. This summer, I worked with Dr. Liu on a project entitled Prevalence of Attention Deficit Hyperactivity Disorder in U.S. Children aged 4 to 17 years old, variations by gender, race, and family structure. The DSM-4 defines ADHD as an impairing mental disorder that produces at least 6 specified symptoms in at least 2 settings for at least 6 months. It is one of the most commonly diagnosed neurobehavioral disorders in childhood and is most likely recognized first at school. ADHD is diagnosed into 3 different types. The inattentive type, which is characterized by behavior such as inability to pay attention to close details, making careless mistakes, demonstrating a difficulty to keep attention, and not listening to when spoken to, among others. The hyperactive type is characterized by fidgeting with hands or feet, talking excessively, demonstrating difficulty keeping quiet, and others. The combined type of ADHD is diagnosed when both inattentiveness and hyperactive traits are equally present. Children that fall through the cracks and are untreated run the greater risk of developing this long list of potential outcomes, including learning disabilities, higher rates of employment difficulties, substance abuse, incarceration, and others. The chart on the right shows that the prevalence of learning difficulties and ADHD in conjunction is almost the same as ADHD without learning difficulties or learning difficulties without ADHD, which shows that it commonly occurs together. As mentioned earlier, ADHD is very common in childhood, with the CDC reporting in 2007 that there are approximately 5.4 million cases of ADHD, which comes out to be about 9.5% of all children aged 4 to 17 years old. Additionally, there has been a 22% increase in the number of parent-reported cases of ADHD from 2003 to 2007. This makes it clear that the magnitude of the problem of ADHD is great and is indeed an issue that raises concern in the field of public health. After noticing the large number of cases in the country, I began to be more interested in some of the socio-demographic risk factors for this disorder, so I looked nationally first. Here is an image from the CDC of the prevalence of ADHD diagnosis based on states in the country. It can be seen that there is a larger concentration of diagnoses on the southern portion of the East Coast. There is still limited information or evidence on why this is, but it's not necessarily explained by socioeconomic status. Perhaps it has to do with statewide policy, views on ADHD, or other factors. In order to get a better look at some socio-demographic determinants for ADHD, I used the 2003 National Survey for Children's Health to get a picture of children's health in a random survey population-based cross-sectional survey. About 105,000 families were surveyed in this study, and ADHD status was determined by a positive answer to the question, has a physician ever diagnosed select child with ADHD? After conducting data analysis using SPSS, it was found that in 2003 there was a prevalence of 7.3% of ADHD. You may recall me mentioning that currently there's an estimated 9.5% prevalence of ADHD. This just shows how the cases have increased over the years. Additionally, 10.2% of all male children are diagnosed with ADHD, while only 4.2% of all female children are diagnosed with it. It was also found that the most common subgroup to have an ADHD diagnosis was the white males, which make up about 59% of all the diagnoses. This graph shows the prevalence by race and gender of ADHD diagnosis. Consistently, regardless of race, males are diagnosed much more commonly than females are. Additionally, white non-Hispanic males have the highest prevalence at 11%, which is much higher than the national prevalence of 7.3%. This graph is a breakdown of the proportion of ADHD diagnoses by race and gender. Again, you can see here that 59% of all the diagnosed cases of ADHD are white males, and 23% of all the diagnosed cases are white females. When it became clear that there were variations in diagnosis by gender, I decided to see if there were also variations by family structure. Interestingly, it seems that there's a larger prevalence across the board of ADHD diagnosis in step families and in families with single mothers. At this moment, the sample size for minority groups is fairly small, and that needs to be considered before drawing conclusions. This chart looks at prevalence based on socioeconomic status by percentage of the federal poverty line and by race. Again, some of these sample sizes are too small to draw some conclusions, but there does seem to be a trend by race and by socioeconomic status. The highest prevalence across the categories is in the white children, and the highest prevalence is also seen in the families that are making less than 100% of the federal poverty line. I was curious whether this was a disorder based on different biological factors or if it was really influenced by sociodemographics mostly. While there are many correlations with developing ADHD biologically, there's no set cause and also no biological test as of now to determine the presence of ADHD. At this moment, there is no reason to believe that there is a biological reason that the white male should be affected more than the other groups. Why does this disease follow a different pattern than most? It's commonly accepted that the minority, low-income, underserved population is the one to carry the burden of diseases. So what is causing this to appear differently in ADHD? Is the national data providing us with an accurate picture of ADHD occurrence? Let's first look at how ADHD is diagnosed. Because there is no biological reason for the disease to occur in one group over another, it is possible that there are disparities in the diagnosis. From seeing that the diagnosis must be recognized in two settings, most likely in school first, and is diagnosed based on questionnaires, it shows that there are potential problems within the diagnosis because it's very subjective. Here's a portion of a sample questionnaire that might be used in diagnosis of ADHD. Many of us would probably self-diagnose with ADHD based on some of these survey questions, such as, when you have a task that requires a lot of thought, how often do you avoid or delay getting started, and many others. This leads to the possibility that there is an underdiagnosis or overdiagnosis occurring. Other literature suggests what is expected, that the low-income minority population with Medicaid is at the highest risk for developing ADHD. Literature reviews suggest that due to a stigmatized association in minority communities of the diagnosis of ADHD, financial barriers which affect access, evaluation and treatment, a lower level of education which can lead to more tolerance of ADHD-like behavior, and poor services available in schools all can potentially be leading to the lower reported diagnosis of ADHD in minority low-income populations. Because ADHD is usually recognized first in school, it's naturally conclusive to note that ADHD symptoms are less likely to be noticed in larger class sizes or schools without proper resources. Excuse me. Additionally, teachers are more likely to recognize ADHD symptoms in African American students. However, African American families more often may hesitate to accept the diagnosis or recommendations. African Americans were significantly less likely to associate the demands of school education on exacerbating ADHD symptoms. Additionally, African Americans are less likely to have heard about ADHD when compared with whites. Finally, African Americans were more likely to incorrectly believe that ADHD was caused by excessive sugar in the diet compared to whites. Parents have described the stigma they are afraid of being associated with ADHD as pressure from family and friends, fear of jeopardizing future employment of their child or ability to serve in the military, that their parenting skills would be questioned, and fear of the unknown. In addition to the personal stigmas or school-based barriers, there are also potential barriers within the medical system to obtaining a diagnosis. These can include lack of insurance and access to health care, negative stereotypes held by doctors, a lack of cultural sensitivity, cultural misperceptions, and a lack of African American healthcare providers or teachers. This poses a problem for policy development because the national data from 2003 does not necessarily suggest that the minority low-income population carries the burden of the disease, while in fact it seems as if they are carrying the burden from other literature and from the possibility of an underdiagnosis. Because this is a potential of being unrecognized and untreated, it seems as though the low-income minority population is indeed carrying the burden of the disease. It is a challenge to truly determine the effects of this disorder because it is being determined in this survey based on the answer to the question, has a physician ever diagnosed your child with ADHD, which doesn't necessarily provide an accurate picture of who has ADHD because we miss those who don't have access to gain the diagnosis. Future studies should continue to look into risk factors and determinants for developing ADHD. The definition of ADHD should continue to become more objective in definition, and underserved communities should be reached out to in order to ensure that they are receiving access to the care needed for a diagnosis. Thank you so much for listening to my presentation, and if you have any questions or comments, feel free to email me. Thank you.